So I'll be kicking off. Thank you. I'll be kicking off today's presentation of reaching the mental health needs of agricultural workers and their families. As Vanessa indicated, I am the Director of Program Services here at the National Center for Farmworker Health. Next slide. So for those who might not be familiar with the National Center for Farmworker Health, we are a private nonprofit organization located in Buda, Texas, which is right outside of Austin. And our mission is to improve the health of farm worker families. And we do that by providing programs, trainings, and technical assistance and resources to the many health centers and farm worker serving organizations across the country. We have over 47 years of experience and are very proud to be able to work with our farm worker advocates. Next slide. Here are some of the learning objectives for today's presentation. So with the information that our main speakers will be presenting, we hope that you will be able to identify common mental health disorders and symptoms presented in healthcare settings by the agricultural worker population. We also hope that you understand the barriers and challenges faced by this unique population and their families as they try to receive and access mental health care. We will also be providing resources and strategies to help you meet your patient mental health needs and ultimately improve their mental health outcomes. Next slide. So we will begin by first describing the agricultural worker population. So this slide here gives you a little bit of a snapshot of the demographics within this community. So it helps to set context to understand who it is that we are talking about when we refer to agricultural workers. So when we talk about this population, obviously they are individuals that work in agriculture. They might be migratory or seasonal, but most of them tend to be male, around 66%. Most identify as Hispanic. More than half are married, and their average education level is about 9th grade. Most speak Spanish, and most have a annual income below the federal poverty level. So they end up also paying for health services out of pocket. So this just gives you a little bit of an idea of the population that we're talking about today. Next slide. So what are some of the common mental health concerns within this population? So farm workers who receive health care services reported in 2019 in the Uniform Data System, which is the latest data that we have available for this. Some of the most common reported mental health disorders were the ones that you see listed here: depression, anxiety, post-traumatic stress disorder. And we also found that this population was at a higher risk for substance use or alcohol-related disorders. Now, for those who already work with this community, you might understand why these common disorders happen, but some of the underlying factors that contribute to this population's poor mental health include economic hardship or poverty, and then the nature of agricultural work. So most oftentimes these individuals are very mobile, they travel often, they move around quite a bit, they work long hours, as well as they don't always necessarily get benefits. So all of that stress can definitely impact their mental health care. Next slide. Here are some of the individual barriers that also contribute to reasons why agricultural workers don't necessarily access mental health care. Like I mentioned already, the migratory lifestyle and just the nature of agricultural work. And because they don't necessarily earn a lot of money, there's limited income to be able to access these services. Now, some of these barriers are also just challenges that the community faces with the healthcare system in general. So farm workers are a very diverse population. They come from various backgrounds. They also have different cultural ethnicities. They have different language necessities. So it can make understanding our healthcare system difficult. Some struggle with health and digital literacy. Like we mentioned, they may or may not have a high level of education. So it's difficult to know how to navigate the healthcare system. They might not have insurance. They might not be able to speak the language to communicate with the provider. So all of these individual barriers are factors that also inhibit their ability to access care. Now, the big one that I do want to really kind of emphasize is the last one, stigma. Stigma has always been a significant barrier for any population in accessing mental health care, including farm workers. There's a lot of cultural beliefs and religious practices that don't necessarily always welcome or encourage people to access mental health care. So it's very taboo for this community to be able to seek services or even meet with a mental health provider. Next slide. Here you will see some of the systemic barriers that impact access to care for this community. And they can include different labor policies, immigration issues, threats of deportation, again, exclusion from health insurance or having limited access to healthcare sites, as well as just a limited awareness of this population. Now, we will touch on the importance of cultural competency later, but this is key when it comes to being able to treat farm workers, just knowing their background, who they are, and having a real understanding of the population, as well as their unique needs and circumstances. Next slide. So here you will see a few strategies that we wanted to share in terms of outreach to this population. Building rapport with them is critical. Oftentimes, they might be a hard population to reach. So working with community health workers or promotoras de salud can be key in being able to build relationships with this community. Being able to listen with empathy to foster that trust is also critically important, as well as meeting them where they are. A lot of these farm workers, like I mentioned, are mobile, they work long hours, so they might not always be walking into your brick and mortar. So we encourage you, if you're able to, do community outreach, go to where they work, go to the local market or different faith churches, communities where they get together and socialize. That could be a better way to reach this population. The other important aspect is really just normalizing mental health in general. Helping these patients understand that taking care of their mental health is just as important as taking care of their physical health. And as health educators and providers, taking a holistic approach can really be helpful in having them understand the importance of accessing this support. Next slide. The last two, like I already mentioned, are really about collaborations, working with individuals that know the community, that can help you provide resources and referrals, and that can allow you to partner so that you can better reach this population. So with that, I do want to start to introduce our featured guest speakers today, because they are an example of one of the key partners that you might be able to consider in collaborating with as an organization that serves agricultural workers. So to start, we have Peter Jensen. Dr. Jensen is the board chair of the REACH Institute, a national nonprofit dedicated to ensuring the most effective, scientifically proven mental health care reaches all children and families. Since its founding, REACH has provided thousands of primary care providers, therapies, and healthcare institutions with hands-on training in the best evidence-based therapies needed to better diagnose, treat, and manage child and adult mental health issues. Prior to this, Dr. Jensen served at the National Institute of Mental Health as the Associate Director for Child and Adolescent Mental Health Research from 1989 to 2000, before moving to Columbia University to assume an endowed professorship in the Department of Psychiatry. Leaving New York in 2000, he joined the Mayo Clinic Department of Psychiatry and Psychology to lead the Division of Child Psychiatry and Psychology, eventually becoming the vice chair of the Department of Research. In 2014, he was appointed professor of psychiatry at the University of Arkansas for Medical Sciences, moving to adjunct professor in 2018. Dr. Jensen has had many national offices and has received many awards for research and teaching from multiple national organizations. Thank you, Dr. Jensen, for being here today. We also have Ms. Sylvia Pang. She is the program manager for the Patient-Centered Mental Health and Pediatric Primary Care Program at the REACH Institute. Before REACH, Sylvia launched a Pan-Asian Immigrant Integration Program in New York City and was part of the team that developed a mental health directory for Asian New Yorkers. Awarded the Anne Cornelissen Fund for postgraduate fellowships, she also spent a year in Taiwan teaching bilingual youth at an international secondary school. Sylvia earned her BA from Vassar College. And last but not least, we have Dr. Lisa Hunter Romanelli. She is the Chief Executive Officer of the REACH Institute and a practicing clinical child psychologist with expertise in cognitive behavioral therapy. Dr. Hunter Romanelli came to REACH from Columbia University College of Physicians and Surgeons, where she was an assistant professor of clinical psychology and the director of the school-based mental health programs at the Center for Advancement of Children's Mental Health. Dr. Hunter Romanelli completed her internship and postdoctoral fellowship at the Yale Child Study Center, and she earned her PhD from Rutgers University and her BA from Harvard University. Welcome so much, panelists. I'll transition it over to you.
Thank you. Thank you so much, Gladys, and Vanessa and Letitia and all that have made it possible for us to be here today. I'm going to go ahead and share my screen. Give me just a minute to hit the right buttons. There we go. So we thought it would make good sense to tell you a bit about this national organization, the REACH Institute, also a nonprofit, but very importantly, to talk about our mission and how it really impacts on what you do as community health workers for your families. So why are we think that's important? Well, in fact, if you look at what's affecting children and adolescents and their parents all across the country, most kids, parents, adults don't get appropriate, high quality mental health care. And so we realized back around the year 2000, so we're going almost a quarter century ago, something different needed to happen to make sure the latest proven treatments reached every child and family and adult across the US, because it hasn't been happening. For a lot of the barriers that Gladys talked with you about, stigma, but also misinformation and lots of other reasons. So we developed this mission that you can see here on this slide to make sure the most effective treatments reach families everywhere. And that's why we're so grateful to Gladys to allowing us to be here today. Now, I will say REACH does four major things. So how do we do what we say we're going to do? Well, one is by training pediatricians and family doctors, nurse practitioners all across the country in how to recognize and diagnose and then treat mental health problems in kids and adults. We do it another way. We also work with therapists to teach them because many therapists are out of date and haven't learned the greatest, most effective therapies. So we teach also in that area. We also work directly with schools, trying to make sure that teachers know what to do, how to recognize a problem if there's a child in the classroom, that it's not just misbehavior or a bad kid. Could be a child suffering from anxiety or depression. And then the last thing I wanted to especially mention, Lisa and I and others initially at Columbia University, we developed something we call the Parent Empowerment Program. What is that? That builds on the assumption that every parent needs to know the best care for their child and then how to get what they need from a school system for their child, or how to speak up to the doctor and say, no, I think we need to do this or that. So they have confidence and, if you will, real competence in pushing forward to make sure their child gets the best right treatment. Sometimes that's a scary thing to do, to speak up and maybe speak back to the doctor. Maybe doesn't know the latest and greatest things to do. So the parent empowerment program, this fourth part of what we teach, teaches parents and parent organizations how to become very strong and proactive, very much like promotores and community health workers who, part of your job is how to help parents take charge and get what they need. So, what are we doing today? Well, we're going to touch on several things. So, we've already done the introductions. Sylvia, you already met, is going to talk about a survey she did ahead of time with the support of NCFH. And so we already have done a survey. And so, in some ways, we've heard a bit from you when you want to share the results of that survey. Then I'm going to talk about some of the some of what we know about misunderstandings. Dr. Hunter Romanelli, our CEO, is then going to talk about things you can do. What are the things you really need to look for? What are the action signs or warning signs? And if you see a warning sign, like a problem behavior, that what you could do, how you could help those families. And we'll have a few resources we'll want to share with you. So let's start off. Let me ask you, now you'll notice on your screen down at the bottom, there is a little box. It's called the chat box. There's also a Q&A box. What I'd like you to do is type into the chat box. It's the one with the little kind of symbol like, dot, dot, dot. It has that little cartoon symbol. Click on that and write down in there very quickly what you think the most common emotional behavioral problems that parents share with you about their kids. In other words, what are their biggest worries? Put that in the chat box, and I'm just going to look and see what you've responded. Defiance. Thank you, Marty. Okay. That's a very important one. Anger. Okay. This is interesting. And we're going to talk a bit about this bullying, self-esteem, being bullied. Or maybe a kid could actually be the bully. That happens too. Use of technology, isolation. God, it's got to be so hard if you're often moving from one setting to another. Laura says very often she sees kids that are hyperactive or aggressive. Uh, okay, well, those are great examples. Now, as I mentioned, Sylvia has actually done a little survey, and she is going to, let's see, she is going to pick up and talk about the results of the survey. So, Sylvia, I'm going to move the slide forward. And so you're typing things in the chat box, but many of you also took the survey. So let's talk about the survey. Go ahead, Sylvia.
Thank you, Peter. So this survey was conducted over the summer, and we really wanted to understand what the children of the farm workers were experiencing, and also learn from you all what has worked for the community and what hasn't. And before we talk about the results, just want to let you know who are some of our respondents. Most of them were community health workers and nonprofit staff, along with some farm workers themselves and even clinicians. And 38% of all the respondents said that their first language was Spanish. We can move on to the next slide, please. And Vanessa just put a PDF in the chat that has a more detailed survey results. Feel free to take a look during the webinar or afterwards. I'm just going to highlight some of the main findings that we found interesting and relevant to the presentation.
You know, Sylvia, I want to just comment on this slide. This is so interesting because what most people put in the chat box already was aggression, maybe ADHD, bullying, etc. But look at so aggression, disruptive behavior, etc., wasn't very common in the survey. The things that were common, look at these top three. Well, ADHD is number 4 as well, but that's actually very interesting and striking.
Yeah, exactly. And that does correlate with the data that Gladys has already presented around adults and mental health. But another thing we want to highlight is that certain behavioral health issues, such as ADHD and autism, were shown to be very common. And it's something that we got to think about. And we won't talk as much in this presentation because of the interest of time, but are there enough training and resources around these topics to support parents in navigating these behavioral health needs? And we can go on to the next slide. So we want to hear a little bit from the audience members here. In your experience, what are some of the biggest obstacles parents face when trying to get help for these youngsters? Similarly, go to the chat function. It would be great if you can put in some of the things you observe.
I see language, stigma. Can you see the chat box, Sylvia? I don't want to say it. I'll let you do it.
Yes. So we have confidence, trust, time, lack of resources, accessibilities, finding appropriate programs for minor, fear. And I want to look at this word cloud that we have on the screen. It is created through a variety of short responses received through the survey, and the word lack came up the biggest. And I think this is highlighted through the chat as well, that a lot of times the issue is when it comes to immigrant community is making sure that the resources are language accessible and are meeting where the children and the families are. And I think that's a big challenge, as Gladys and Vanessa have highlighted, with the farm workers community. And that could make the mental health issues faced by these children even more difficult. If we could go into the next slide, thank you. And we just want to preface that, children are not robots, humans are not robots. Emotions do happen when external stressors occur. So short-term emotional responses and emotions are actually quite normal in children. These include depression, worries, anxiety, sadness, and other short-term behavioral problems. And on the short term, these emotional responses can be non-severe problems for children, and they might be experiencing multiple emotions at the same time. And a good example is, often kids go into high school and now they're faced with more independence. And this could add additional stress to them. But if a school and the family and their friends are supporting them through the process, that's how when children develop and find new skills and strengths. However, moving on to the next slide, there are times when these emotional responses become long-term. And that is what we're going to be talking a lot more, as Dr. Peter Jensen will in a bit, about what to do in these situations. So in the chat box, I'm going to skip over the first question. I want to hear, what do your families believe causes these emotional problems in children to last a long time and become very severe? What are the causes that, we develop into this problem of long-term emotional challenges in children? What causes mental health problems? Might be a little bit more of a challenge. Oh, I see. Not addressing the emotions, trauma, lack of attention, technology with social media. That's a big concern among parents, family conflicts. Let's move on to the next slide. So I think the audience member here are obviously very knowledgeable. You guys serve the communities, are well equipped with understanding mental health needs. So you know that there are certain systemic problems that may cause mental health issues. But what we found in the survey is that a lot of the farm workers' parents actually have a bit of trouble in understanding that and trying to deduce why are our kids struggling from certain things. Here are some misunderstandings that we saw. There are more that are in the survey short responses I encourage you to read through. But a trend we see is that some parents don't believe that, children can have mental health problems. There's a level of denial and normalizing discomfort and ignoring the symptoms. On the other hand, we also see, if we go to the next slide, that there's this trend where there's guilt and parents feeling guilt in their own parenting skills, or they think that the children are just acting out and putting the fault on them. And these misunderstandings can make it very difficult for parents to know when and how to take the next step in addressing these emotional behavioral health issues. So I'm just going to transition now back to Dr. Peter Jensen in showing some of the science behind these mental and behavioral health issues, and also beginning for us to understand how to talk to these families and in addressing it in an accessible and approachable way.
Thank you, Sylvia. One of the things that contributes to stigma, I believe, is that parents end up feeling some blame or shame, almost like maybe I caused the problem, or other people will blame me and think that there must be a bad parent. Now, we've looked at that question for many years now in lots of research. What the research shows is that parents don't cause mental health problems. Now, they may do things like not get help when the child needs it. Maybe they don't recognize it, or there could be family stresses that may make things worse, but it doesn't really cause mental health problems. So that's important to address that stigma right at the very beginning. But we do know there's lots of other things. So, for example, what happens if you're a migrant farm worker and you're moving to place with few resources and no steady friends? Could that make additional stress and precipitate problems like maybe depression or anxiety or misbehavior or falling behind in the classroom? Absolutely. So it's important that we always kind of look at other potential causes. And you can see right here, there's a long list. Trauma, exposure to drugs, even poverty itself can have longer term effects. Racism, having difficulties prenatally in the womb can affect a little bit of brain development. So there's a whole range of science-based findings of things that are important that we do know we need to attend to. So now it cuts both ways. You can do all kinds of positive things that will improve a child's mental health and their functioning. And so, for example, these are very obvious, but they're so important. We always need to put them front and center. A child needs to feel loved. Now, think about that. Feeling loved is not the same as a parent telling a child that they're loved. And so when I work with parents, they say, "Oh, I love my child." But we have to do a lot of work. How do we show the child that love so the child feels loved? Because the real goal is not saying it to a child. The real goal is for the child to feel loved. But if the child is going to succeed, they have to be good at things. They have to have skills or talents. So how do we support a child? They may not be good in school, but what if they're really a good soccer player or a good friend or good at art? So how do we do that? We also know that while those two things are important, every child needs at least one or more best friends. And of course, these other factors of nutrition, sleep become very important. So that's always important when we think about how to address mental health issues. Is the nutrition adequate? Is the home safe? Is there bullying in the neighborhood, or is the neighborhood safe? Because all of those things will affect a child's mental health. Now, fortunately, even though there's stigma, we have some pretty good tools, rating scales that help us figure out, does the child maybe have problems that we should address, that we should treat, that we should do something about? Think of it like a blood pressure cuff. When you go to the doctor, he or she puts a cuff around your arm and checks if you have blood pressure problems. That's a test. It's a medical test. Well, we have tests like that in mental health too, but they're mostly checklists that we get from a teacher and a parent or even from a kid. And what we've learned is those checklists that have been validated, rigorously tested, can help us determine whether a child is likely to have a mental health problem. And by the way, it should be important to note, when we study mental health problems, we find them in every country in the world. We find them in the Sudan. We find them in South Korea. We find them in the Philippines, in the US, in Nicaragua, in Mexico, in Canada, and of course here in the US. So it's not a US problem, it's a worldwide problem. And that's why worldwide parents and healthcare providers need to know what to look for and what to do about it. Now, if you think about the kinds of mental health problems kids might have, here's a nice summary. So this is for the US. And so notice these percentages here. Well, about 8% of US kids in a given year will have depression. Now, during COVID, these rates increased most likely. Same thing with anxiety, 8%, but these rates may have come close to doubling during COVID, as best we can tell. And there are behavior problems. What does DBD stand for? It stands for disruptive behavior problems, like a kid who has aggression, okay? Or ADHD, notice the frequency. Substance use problems, that's substance use disorder, or autism. Well, altogether, this is 20% of the US population of kids. And some of these kids, these percentages, notice, add up to more than 20. If you did the math here, that looks like about 30, 33. And that's because some kids have two problems or three problems. And so it's about 15 to 16 million children total here in the US. So it's a very important problem. Now, parents blame themselves, so we've got that worry. We've got to worry about stigma. But as I mentioned, parents don't cause it, but we need to make sure the environment is as positive and healthy as possible. But genes are important. Sometimes you can inherit a tendency for ADHD or depression or anxiety. But other bad things can happen in the environment, including a brain injury. And all of these things come together to predict the likelihood of having a mental health issue or being more healthy, if you will. So now, why is that important? Because look what happens if we don't treat them. We have to recognize them and we have to treat. And so here's a nice long list, and it's a sad list, but look at what we have. Yes, suicide, the most common cause of death in kids 14 to 21 now is suicide. More common than any form of cancer, any other illness. Second now is auto accidents. So suicide, auto accidents, and then all of those other medical causes. But lots of kids go on to have other kinds of problems like school failure and dropout, injuries, long-term problems, substance use, or maybe they perpetrate violence. Divorce is is more likely if you've had a stressful childhood, you're more likely to have stressful adulthood and maybe have a divorce, and then that is going to affect your kids as well. So we always like to think about how do we meet kids' mental health problems, and let's focus on where the needs aren't being met. What do we do? What do you do? What can all of us do? So most kids, very sad, their needs are not met. What do I mean by that? They don't get a diagnosis and they don't get any treatment. Okay. Now, the highest unmet needs, think about, and it's about 75% of kids with mental health problems don't get much care at all. But it's higher still among Hispanic kids, kids of color, uninsured kids, and our highest uninsured rates. Look at this. Also, the same places where we have so many migrant farm workers. So that's kind of a very bad combination of those two things coming together. So why is this happening? Again, lots of times, sometimes we do have services, but if family's afraid, the stigma, or maybe there's worry that it'll have an impact on the child. Now, you already mentioned language, but for farm worker families, just think about all of these relocations, moving around. How does that interfere with getting care? But here's something you can do a lot about: lack of awareness. What can you do to educate your parents to say it's not your fault? And here's a funny way to say it. It's not your fault, but it's your problem. What does that mean? I'm smiling, but that means that they didn't cause it, but it's their job to figure out how to fix it. It's not their fault, but it's the problem that only they can really begin to try to fix. Now, let me pass on the baton to Dr. Lisa Hunter Romanelli, who's going to give you some nice, useful summary points about what we call action signs, meaning where can we act? What can we do? What can we make a difference? Meaning where can you and I both make a difference? All right, Lisa.
Thank you. So as Peter said, I'm going to be talking about the action signs. And the Action Signs Project was a research project that we did at the Reach Institute in collaboration with some other folks. And we got a lot of input from family members on what are some feelings and behaviors that when they're present in children, it's a reason to be concerned and it's a reason to take some action, meaning having the child evaluated by a professional. And sometimes the presence of these action signs means that the child actually needs some help or treatment. So there are a total of 11 action signs. I'm going to be talking about 4 of them related to depression and anxiety. And we created an action sign toolkit that looks like this, but it's also, we have paper versions and there's also an electronic version. And the toolkit goes into more detail about all of the action signs, and there are a lot of helpful resources in here that, you know, teachers, other folks who interact with kids and families can use. So next slide, please. So these are the two action signs related to feelings of depression. And the next slide has two action signs related to anxiety. And so I'm going to go into both sets of those action signs in a little bit more detail, starting with depression. So this feeling very sad or withdrawn for more than 2 weeks, this is a really important sign to know because the presence of it may indicate that the child is suffering from depression. And as we talked about earlier, as Sylvia mentioned, everybody has feelings. So everybody is going to feel sad sometimes, and that's okay. But if kids are feeling very sad and withdrawn, and it's lasting for more than 2 weeks, that's something to be concerned about, and that's something that we need to take action. So that one is a really important one for you all to be aware of. The next action sign, so what can you do if a parent or if a child is reporting that they've been feeling sad or withdrawn for 2 weeks or more? The first thing is to encourage the child and the family to talk about it with a professional. And that professional could be a doctor, like a pediatrician or a family physician, a nurse, or a school counselor. Talking to someone can really make a difference. The other thing is that there are things that the child can do or the child's parents can encourage them to do that will also help. So for example, we know that things like getting a good night's sleep, being physically active, and also interacting with other children or other people, that can help with feelings of depression. And those are all things that are doable. So that's something else that you can encourage children who might be feeling depressed to do. Lastly, sometimes for some kids, they actually need counseling to help with the depression. And in some cases, medication also is necessary to help alleviate symptoms of depression. So those are kind of the three things: talking to a professional, encouraging the child to get good sleep, exercise, and to be engaged. And then lastly, considering either counseling or medication to help with depression. So this action sign, of course, has to do with suicide. And Peter presented just a minute ago how suicide is one of the leading causes of death for children. And that's awful, and it's tragic every time that it occurs. So if any child is talking about trying to harm or kill themselves, that is absolutely something that you must take action about, because not taking action may lead to the child dying and actually succeeding in killing themselves. So what can you do if you know of a child that is thinking about suicide? One of the best things that you can do is talk about it. Talking about suicide or talking to somebody who's thinking about suicide actually reduces the suicide risk. And this is hard for people because some people may think that, well, if I ask a child, are they thinking about hurting themselves? Are they thinking about killing themselves? Am I actually kind of making them contemplate doing that? And the answer is no. Asking about suicide does not cause suicide. It actually reduces the risk, because if we're aware as caring adults that a child is contemplating suicide, we can do things to help prevent that and help them see that there are other options. It's important to understand that suicide is very much linked to depression. So by treating depression, you're also reducing the risk of suicide. And we talked just a minute ago about the different ways that depression can be addressed. These are some other kind of tips, again, for helping with depression and suicide. So again, conversation and talking and problem solving with kids is really important, particularly for suicide. We want to make sure we understand what are the risks in terms of safety for the child. So if we have a better understanding that the child is thinking about suicide and we know how they might be thinking about killing themselves. So for example, if a child is thinking about shooting themselves, we want to make sure they don't have access to guns. If they're thinking about stabbing themselves, we want to make sure that there's no access to knives, pills. So if the more we know about what the child is thinking, the better able we as adults are to protect them in terms of their environment and limiting access to means of committing suicide. And then, as I mentioned before, treatment therapy is very important for kids who are contemplating suicide, because that is going to help with the depression and also help them develop other ways of coping with the stress and the other concerns that are leading them to think that the only answer to feel better is to end their life. So moving on to the next category of action signs that I'll talk about today, this one has to do with anxiety. So again, everybody worries. We all worry sometimes, but when those worries are intense, or kids have fears that get in the way of them doing what they need to do day to day, that's important to be aware of, because it could be a sign of an anxiety disorder. What can you do if a child has intense worries? So these are just some pointers about anxiety. Really severe anxiety can affect all areas of a child's life, school, friendships, family relationships. And sometimes kids who are anxious kind of slip under our radar. So in schools, for example, anxious kids usually are pretty well behaved. They're doing what they're supposed to be doing. So teachers and other adults in schools may not recognize that the child is actually suffering from anxiety. So again, that's where talking to kids and noticing how they're interacting can make a difference. Just like I mentioned for depression, conversation with kids and helping them identify what is causing their anxiety and worry, that can make a big difference in helping to alleviate anxiety. And again, of course, counseling and medication also can be helpful for anxious kids. So here's a summary of some of the things that are important to keep in mind when we're thinking about how do we recognize potential mental health issues in kids. The first is awareness. So the action signs are one way. Learning the action signs, we only talked about 4, but there are 11. So the more aware you are of those action signs, the better able you'll be to recognize them in other children. Another thing that's important is to encourage families to reach out to you or to others for help when they're concerned about their child or when a child is struggling. We've all talked about stigma. So understanding that stigma can be a barrier to recognizing mental health issues as well as seeking care for them. That's important. And then misunderstandings about problems that kids have, those can often prevent parents and other adults from seeking care for their kids. So a common one is, the child is just going through a stage, they'll get over it. Being depressed, being severely anxious, that's not a stage, that's a mental health issue. And a kid won't just get over it. They really need help in order to do that. Another common misunderstanding is that it's not really a problem. Everybody feels depressed or something like that. And that's also a misunderstanding. That's not true. It's different. Sadness and depression are 2 different things. And these mental health concerns really get in the way of children's functioning. And they lead to kind of some of the negative outcomes that Peter talked about before. You all can be particularly helpful in identifying available resources for families. So we have some listed here. Schools can be a great resource, counselors developing, making sure that kids who need them have special education services as well as 504 plans. And then we have a bunch of different websites listed there that can be helpful to increase your understanding as well as to share with parents so that they can get a better understanding as well. So we wanted to spend a little bit of time talking about like what are some best practices to help children and families who have mental health issues. We have some listed here, but I also wanted to invite folks to put into the chat any thoughts that they have, that you all have about what are some best practices that you can do to help children and families with mental health concerns?
I just moved that slide forward, Lisa. There was a
Sure.
lot of information on both, and so hopefully that might be useful jogs for people to throw more ideas into the chat box.
Yeah, that's great. So let's see.
Thanks for putting all those links in, Gladys. Notice they're all the links we provided are also in Spanish.
Fine. So thank you, Marty. Support groups for families, that's a great idea. And those can be really helpful just to help families realize that they're not alone in some of the challenges in helping children with mental health issues. And support groups are a great place to get resources from other families who are going through the same thing.
Other ideas.
Yeah, other ideas.
Don't be shy. Some of you have been doing this a lot already. And so what are the secrets that you've found, or what are your biggest challenges for supporting families? But what are the best practices?
Trainings, yep. Faith-based communities can be very helpful in providing support. Education and awareness. Culture is often a barrier, and so the more that you can, I think people tend to listen to folks who they share some commonalities with, and if that's culture or they both have children, that often can help break down some of the barriers. So that's a great idea. Resources is a challenge in different languages. And transportation. Yeah, the transportation is a big issue, and that's why schools, for example, being able to provide some services in a school setting so children are more likely to benefit from those services if they don't have to go to a clinic. So providing mental health services where children and families are can make a big difference. So thank you for sharing those. And for those of you who do want to provide education, like I said, the action signs, we're happy to share those electronically with folks, and you're welcome to use that in making presentations to families or others around how to recognize mental health issues in kids. So here, our contact information is listed here. And you're welcome to contact any of us if you have further questions.
Just a quick question for you, Lisa. Don't when you and I worked on the Action Signs project, didn't that all of that get translated into Spanish? And as I'm thinking, CMS did that. I'm sure we have it in Spanish somewhere as well.
That sounds familiar. I don't know where that exists, but I'm sure we could figure it out.